respiratory symptoms like wheezing, potentially gastrointestinal symptoms. Hypotension is something we worry about. And generally, they don't last for multiple days. It's usually an immediate reaction that occurs around the time of exposure and is gone the next day. Now, that's not the only immunologic reactions. Reactions like heparin-induced thrombocytopenia, where you could develop an antibody that leads to thrombocytopenia induced by heparin has certainly been described. Immune complex reactions, classically, this would be a delayed reaction, maybe a week or so later with body aches, maybe some systemic symptoms like fever. Serum sickness-like reactions are classic. It's a classic description for this. And then the T-cell mediated reactions, again, delayed onset, but that has a wide variety of manifestations, with the most benign reactions being the classic delayed maculopapular rash, and then what we worry about, the severe cutaneous adverse reactions. And so I think it's worth talking about those two because, again, that's what we're interested in when we're trying to evaluate a drug allergy. And so the classic story for like the type 4 benign T-cell mediated reactions is you'd get a rash like this. It's generally flat or slightly raised, maybe a little bit itchy. It will last multiple days. So urticaria is classically described as a transient rash that disappears less than 24 hours later and resolves without residual mark. More maculopapular rashes in a benign T-cell mediated reaction may last for a few days and then might have some fine desquamation or some maybe residual skin changes over days to weeks. And so, clearly asking that question in your history about the length of each lesion helps you distinguish between those two common rashes. Now, what we worry about are the severe cutaneous adverse reactions, because upon re-exposure, that could cause significant morbidity to the patient. And so we'll start with some of the classic ones. I know I'm being a little abbreviated here for the sake of time, but DRESS syndrome or drug rash with eosinophilia and systemic symptoms is one of the examples. Systemically ill patient, 2 to 8 weeks after exposure with fever, acute rash, maybe some immune activation with some lymphadenopathy, multi-system organ involvement, like transaminitis of the liver, and maybe hematologic abnormalities. Clearly, they'll have eosinophilia under peripheral blood. There is a Registrar score that you can use to assess these patients. And a classic example of this would be something like anticonvulsant hypersensitivity syndrome or so on. Now, I think everyone is familiar with Stevens-Johnson syndrome, right? This is more of desquamation, mucositis, blistering, or bullae. And we worry about this because if enough skin involvement occurs, over 30%, toxic epidermal necrolysis, or TN, is possible. These patients end up in the burn unit. There is a significant mortality to this. And clearly, the assessing for the presence of bullae or mucositis is essential in the history of an allergic reaction. And, multiple drugs can cause this, but, classic examples are like sulfa allergy or cephalosporins or so on. And then the next one we should think about is AJEP reactions, right? And so those are typically more quicker onset, 1 to 2 days. Generally, it'll be this erythematous plaque base with sterile non-follicular pustules. And, those all have been described with beta-lactam antibiotics. Hydroxychloroquine has been associated with diltiazem and other drugs and other antibiotic drugs. And so, when we are trying to get the history of allergy, if someone says, I'm allergic to penicillin, we'll naturally try to ask them, well, what happened when you took it? And then does it fit in a known reaction, i.e., is it just a side effect, or is it an immunologic problem? And then what type of immunologic problem? Now, obviously, I'm talking about in an ideal scenario. What happens in real life is that actually penicillin allergy is actually very poorly documented. How do we know this? Well, if you assess electronic health record system data, you might get examples like this. The North Shore University Health System looked at their electronic health record. Of the 15.6% patients who reported a beta-lactam allergy, only 22.7% actually wrote what happened when they took the drug. So no one had really any idea what the reaction was. It was just documented in the chart. When they've actually tried to explore this further, so the partners group, like I mentioned before, in Boston, actually looked at what are the most common labels people actually put in for allergy reactions. Well, number one is rash. Well, what kind of rash? Urticaria, AGEP. I told you about 4 different rashes just now. It doesn't say, right? It just says rash, right? Number 2 is unknown, right? Again, not very helpful. We don't know what was the classification of reactions, but some of the ones you could see that you could sort of figure out what's going on, right? Hives and angioedema. Maybe we're worried about type 1. Gastrointestinal upset. Okay, maybe we're worried about more of like an intolerance or a side effect or so on. Or itching. Again, very non-specific. We'd have to determine if that was with rash or not and what kind of rash. So you could see the lack of documentation of the label makes it very hard to us to evaluate the patient's risk. And so certainly one area of improvement we also think about is, are we able to do a better job of helping our colleagues and our patients by getting a nice history on what is going on with the allergy label? And, you might say, well, you don't want to take a risk. And certainly we don't want to cause patients harm. But interestingly, if you actually challenge patients, if you actually give patients with reported penicillin allergy, the drug, it appears that less than 5% actually have a clinically significant reaction, meaning they have either benign symptoms or no symptoms whatsoever. And so why is that? Why would there be just 95% of people who actually report a penicillin allergy have no problem taking it? Well, there's a lot of confusion on, penicillin allergy diagnosis and, actually placing the label. And so I'll give you some examples of why this can occur. Number 1, rash is a manifestation of infection, right? So if you're sick and you give an antibiotic and something happens, is it the infection or is it the drug? Who knows, right? No one's evaluating that. In fact, the most common cause of hives is not even allergy, it's infection. So 10 to 20% of the population has urticaria, and it's the most common cause of hives. So, infection is the most common cause of hives. Number 2, we know the interaction between penicillin and EBV. So there are many, 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 many children who have EBV type symptoms, maybe pharyngitis, and they get amoxicillin. And guess what happens? They get a delayed rash, which is well described to be the interaction between the infection and the antibiotic. And the third thing is, interestingly, even if you did have a true IgE-mediated reaction to penicillin, skin test data longitudinally over time has showed a decrease in the positivity of the skin test over years, potentially decreasing by 10 to 20%. And so you could see here, in terms of people allergic to amoxicillin or allergic to another component called benzylpenicillin, even after 5 years, maybe the risk is under 50% potentially, or even 0, right? So even if you did have a type 1 reaction, given enough time, a lot of patients do have resolution of their allergy to penicillin. So it is not considered a lifelong condition. So I've already told you that they're common, but maybe erroneous. What's the big deal then, right? I mean, you could, maybe you're a very cautious person and you don't want anyone to have any reactions. Well, we have to consider what is the consequences if we just go with the flow and just give an alternative antibiotic. And so I think we gave another example recently with the questions, right? You were worried about cephalsporin allergy, so you decided to give the patient Vanc, right? So what are some of the potential consequences of that? Well, there are certain antibiotics that work better for certain infections, right? So if you had to go head-to-head between Vanc or amoxicillin for MSSA, most ID physicians absolutely would want you to give the beta-lactam. And so when you get the non-ideal antibiotic choices, there's a potential for treatment failure, right? Number 2, it has actually been documented that if you give a non-beta-lactam antibiotic for prophylaxis, you will have an increased risk of surgical site infections. So beta-lactam antibiotics are actually more effective in protecting against surgical site infections. And then we all know about resistance, right? Resistance is an epidemic in this country, right? There are hospitals out there where they have to like take apart the whole unit to get rid of these infections. And so certainly overuse or overprescribing of broad spectrum antibiotics, especially for an erroneous diagnosis, not only increases the risk of resistant bacteria, but potentially complications, as you know, like antibiotic associated C. difficile. So taking that together, treatment failure, increased surgical site infections, increased resistant bacteria, as you can imagine, there's going to be increased morbidity, increased inpatient length of stay, and increased healthcare costs. One estimates that in a systematic review, potentially 1,100 to 4,000 per patient, depending on the study that you look at. And so if you think about all the people with penicillin allergy, 10% of your hospital discharges, I mean, I'm not sure how many discharges UofL hospital have, maybe 10 to 20,000 a year. You can imagine 1,000, 2,000 times this is millions of dollars. So again, it really adds up. So what's the summary thus far? Penicillin allergies are very common, but actually, if you think about how many are actually true allergy, it's probably less than 5%. And so if we just go along with this, especially 95% of patients may be having increased morbidity, increased complication, and therefore increasing costs to the institution and the healthcare system. So we need solutions. So how are we going to remove these inappropriate penicillin allergy labels? Because I do agree with you. We don't want to cause harm to any patient, right? We're going to do it the best we can to do the best thing for our patients. And so we're going to need to be empowered to evaluate penicillin allergy. And so, it goes back to preclinical again, history. The story is everything. I've already told you certain known allergy syndromes and certain questions that can help you elucidate and estimate the risk. This is from the JAMA article, which I encourage you to read. They have this supplement that gives you a toolkit that you can implement in any institution to evaluate penicillin allergy. And really, your big question is, what happened when you took it, right? And so you can imagine there's different tiers, right? Maybe they had some stomach upset. Maybe they had a headache or fatigue. Well, those are not actually classic for immunologic reactions. Those are considered intolerance. Maybe it's a low-risk history. They're avoiding it because their mom had a reaction, but they never took it in their life, right? Well, how does that make sense? You don't know they're allergic. I do agree that there are genetic predispositions to certain medications and antibiotics, actually antivirals, but actually penicillin is not one of those. Penicillin is not increased, you do not have an increased risk of penicillin allergy with family history. Itching in isolation or don't remember, right? So that's considered low risk. Moderate risk would be, again, potential Ig-mediated reactions, right? Anaphylaxis, urticaria, and so on. Syncopizing, right? So now you're going to be a little concerned. And then we talked about the severe cutaneous adverse reactions. And some of the warning signs that have been described is fever, painful skin, mucositis, like Steven Johnson symptoms, central facial angioedema, purpura, right? So like duskiness or EM, erythema multiforme type rashes. Oh, I forgot to mention this. Did you take the drug since the index reaction, right? So some people say, well, I'm allergic to penicillin. Well, what drugs do you take for sinus? They might say Augmentin. Well, Augmentin is basically a penicillin antibiotic, it's amoxicillin, right? So, sometimes it's kind of, people don't think about it, right? But, it kind of slides underneath the radar that they actually tolerate the penicillin after their index reaction, right? I want to bring you this article from Elizabeth Phillips in Vanderbilt. So you could see, I'm going to be quoting the same big names over and over again. So Jason Trubiano and Elizabeth Phillips from Vandy, Kim Blumenthal from Massachusetts General, Eric Macy from the Kaiser System in Southern California. This is from the Vanderbilt group. So they said, okay, well, we're going to validate this just quick clinical decision rule. And basically, a rapid assessment would be, okay, they have penicillin allergy. Is it recent, right? I told you it fades over time, right? Did you have anaphylaxis angioedema or a scar, right? Or and do you need treatment, right? And so just very simply on a 5-point scale, you can risk stratify somebody, right? So again, the reference is here in JAMA Internal Medicine. So, okay, you get this history. Who do we just delabel? Who are the people who just say, okay, we'll just delabel it, right? Well, they never took the drug, right? So I know that's kind of funny, but like some people say they're allergic, but they never took it. So how would that happen? Well, most of the time it's family history. Most of the people who are avoiding the drug, but never took it before, and they say they're post-allergic, is because a family member was allergic. And again, that is not a high-risk condition. If you get the history of it's an intolerance or side effect, it's maybe a reason to label a drug. Or again, you got that allergic to penicillin but took an augmentin reaction, right? Then they tolerated the drug after the index reaction. Then we know that they passed the test, right? They are able to take the drug. Now, low-risk histories is when we're going to try to attempt some delabeling, but it's going to need maybe some evaluation, right? And so the low-risk history would be, like I said, mom told me, but I don't remember, right? So that could be anything, right? Itching without rash. Now, again, I should note also the 10 years, right? It fades over time. So even if it was anaphylaxis, it's lower risk. Itching without rash. I told you about benign type 4 reaction, the delayed maculopapular rash with the lesions lasting longer than 24 hours. Again, these were probably more of a low risk type history. And then I think I already told you the warning signs for the high risk history, right? Fever, the painful skin, or duskiness, or Stevens-Johnson's type symptoms, any severe cutaneous adverse reaction, like I mentioned, maybe type 2, type 3 hypersensitive reaction, so serum sickness, or cytopenias, or some sort of cross-reactive cytotoxic reaction. And then, there's liver injury, there's, hepatitis due to certain drugs. So, cutaneous, drug-induced lupus is another one. So again, you're going to get some higher risk histories where you're going to be a little bit more gun shy. So I talked about evaluation. So for the patients who we want to do some sort of evaluation to assess their risk, we have to get testing, right? So this only assesses for type 1 reactions, right? So we can only assess for the risk of anaphylaxis or highs. This doesn't tell me anything about serum sickness or Stevens-Johnson's. It's only going to tell me, does the patient have a risk for anaphylaxis? And so you would, again, do a prick test here. So you can see this Lancet. We use two different components here. One is just penicillin G, and then available commercially is the major determinant for penicillin, which is a metabolite. It's called benzopenicillyl polylysine, right? And so we usually do that in a prick, and also we do an intracutaneous test. And generally, if both are negative, it has excellent negative predictive value. If you have absence to IgE on skin testing and intradermal testing, you probably have less than 4% chance of anaphylaxis. So it's immensely reassuring. Though most of those patients do get challenged just because of that, 1 to 4%, especially with a history of anaphylaxis. Now, an example of what the testing looks like would be this. So here you could see a positive histamine. That's just making sure there's no allergy medicine in their system. And you can see there's no reaction to penicillin G or the polylysine, right? But as you can see here, here's a positive reaction, right? And you can clearly see the difference between the two. Now, no test is perfect, right? We know that. We've taught that as a principle of epidemiology. And so I already told you the limitations, that it's not going to evaluate for like delayed T cell mediated reactions like that, maculopapular rash. The skin test is not going to tell me anything about that. But also, the actual reagent sometimes is irritant, right? So you could get a red mark that is incorrectly interpreted as a positive test. And so, for example, there was a recent study where 25 patients actually had a positive skin test. They just went ahead and challenged them. They just challenged them anyways. Only 36% actually reacted, right? Which is very surprising, right? You have a positive skin test. So the negative predictive value is pretty good, but the positive predictive value does have some issues, right? And so the sensitivity of the test is variable. One study quoted amoxicillin allergy skin testing sensitivity is 10%, right? So I think the testing is more helpful if it's negative, but could perpetuate a label if it's incorrectly positive. Now, drug challenge is another issue, right? So drug challenge rules out both immediate and delayed reaction, right? So if they take it, nothing happens, that's the gold standard test, right? And certainly, because we are risking an allergic reaction, we're going to perform that in a hospital setting, ideally in the presence of an allergist immunologist, or someone with the experience with treatment anaphylaxis. But, we won't do it on everyone. If someone's obviously critically ill and can't tolerate an allergic reaction, if they're at some sort of respiratory issue, beta blocker therapy would be the concern of antagonizing epinephrine therapy if we needed to rescue an anaphylactic reaction, pregnancy, and maybe recent antihistamines, because that's going to mask the earliest sign of allergic reactions. Those might be some precautions. Maybe you may not want to do a drug challenge immediately. And generally, there's both single dose or two-step challenges. I haven't seen a difference between the two. Maybe you want to do two-step if you're a little bit more worried. But generally, most protocols say give 250 to 500 of amoxicillin, wait an hour. If nothing happens, most type 1 reactions occur within an hour. So generally, if nothing happens within an hour, and this can be done in an outpatient setting if properly equipped, again, you could probably successfully delabel them. Now, 3 to 5 days later, could they have a macular papular rash? It's possible, right? And then therefore, right? Now, would that potentially lead to harm? Well, if you took a good history and you didn't see a severe cutaneous adverse reaction, it's probably going to reproduce the previous rash. So again, a careful history is also very important. Now, I just told you two options, penicillin skin testing or drug challenge. So what should we do? Well, people looked at this in a randomized fashion. So there was a randomized control trial that took patients 5 to 90 years of old. If you were 5 to 18 and you had a history of a cutaneous only reaction more than a year ago, or if you were an adult, it was more than 10 years since your last reaction. So these are low risk patients. Basically, they had 159 patients, and basically half of them got skin testing, and then half of them got challenge, went straight to challenge. And 10 out of the 80 skin test positive individuals, 80 of the 80 skin test individuals, 10 of them probably had low level, probably false positive results, right? But in the other group, in the 79 randomized patients, they underwent a two-step challenge, and there was 3 minor reactions, but no epi was used whatsoever. So you could see that they were able to delabel 79 patients on the challenge version, where they only able to delabel 70 patients on the other group. So you can imagine there was sort of a trend with less individuals being delabeled in the skin test group. And I already told you about that concern about the false positive rate. If we challenge those 10, could they have passed? It's possible, right? It's possible. So we spent a lot of time about penicillin. Let's talk a little about cephalosporins. So you've ever heard this? One senior doc passes to another and passes to another. It's just sort of like knowledge that passed throughout the generation that there's a 10% cross-reactivity between penicillins and cephalosporins. Interestingly, newer data suggests that the cross-reactivity between penicillins and cephalosporins could be quite less because the reactivity is not based on the beta-lactam, but rather the R chain. R chains seem to be the primary determinant of cephalosporin cross-reactivity, not the beta-lactam ring. So if you have two drugs with the similar R chains, even if they both have a beta-lactam ring, the cross-reactivity seems to be less than 2%. So really, to be able to assess risk in cephalosporins, you have to be familiar with which drugs have similar R chains. And so we'll just briefly, I'll show this first here. In terms of penicillins in general, the cross-reactivity between penicillins and cephalosporins, again, is less than 2% unless they have the same R chain. If you have penicillins and carbapenems, it's been shown to be less than 1%. And then monobactams, 0%, right? There's absolutely no concern of cross-reactivity. But getting to that R chain point I was saying before, these are sort of the known groups of R chains in each column where they share a similar R chain. So for example, here's ceftazidime and azoxystrobin. Here's ceftriaxone and cefotaxime. Makes sense, all right? They're both third generation, right? And then here's amox-amp with cephalexin, right? Keflex, right? We see that a lot. And so you could see that, here's the R chain for ampicillin and amoxicillin that's shared amongst these groups. Here's the R chain for ceftriaxone. But the one R chain I want to bring to your attention is cefazolin. So we talked about surgical site anaphylaxis. Interestingly, cefazolin has a very unique R chain, which is not shared by any beta-lactam, cephalosporin, or penicillin. It is actually its own unique R chain, right? So I just told you that R chain reactivity primarily determines cross-reactivity. So that suggests that patients with penicillin allergy, even if they have full-blown life-threatening anaphylaxis, have very low risk for cephalosporin allergy. Well, how do you prove that? Well, you give them cefazolin. So that's what we did here. So we implemented, and when I'm in lean, I have to give most of my credit to my colleague, Dr. Marin Kuravella, and then the antibiotic stewardship physician, Dr. Mary Beth Sexton. And so in a systematic implementation for quality improvement in the Emory system, once we get the history of allergic original reaction to penicillin, we risk stratified accordingly. So if they had a SCAR, severe adverse reaction, we probably said, just for safety, we're not evaluating them, let's just avoid. But if they had IgE-mediated reactions, if they had an unknown reaction, if they had non-specific benign rash, doesn't matter. Give them cefazolin, right? Okay, well, what happened? Well, prior to implementation, only 22% of penicillin allergic patients received a cephalosporin, but after the implementation of this clinical decision rule, that went up to 80%, or 551 patients, where we had no immediate allergic reactions to epinephrine, one patient who had a delayed rash, so again, they did have a reaction, but it was not severe, and 3 patients reported itching, and they did get diphenhydramine, but they also get the opioids. So, it's kind of hard to say, was it the opioids or the drug? So again, depending on the type of reaction, you could see there was rates of cefazolin use between 20 or 40% at baseline, but you can see in the orange, after the clinical decision rule, we are hitting above 80%, 85% or more with implementation, with, again, very few consequences because of the new knowledge gained about cross-reactivity between cephalosporins and penicillins. So, taking everything that we've known, what we know about how to evaluate penicillin allergy, what we know about cephalosporin and penicillins, is there a way to, again, apply that beyond surgical site infections to all inpatients? And so that is what we've been doing for the past year. I apologize that the data is currently being analyzed, so I can't share that to you now, but I'd be happy to show you the algorithm. So essentially, we're going to ask that question, what happened when you took it, right? And as we mentioned before, drug, fever, liver involvement, severe cutaneous reactions, we're obviously going to avoid the drug. Now, if you have intolerance, nausea, vomiting, diarrhea, you're avoiding it because of family history, give, not a clear, just give them whatever, right? Give them, penicillin, cephalosporin, whatever you want to do, right? Now, obviously, the type 1 reactions or unknown is where it gets a little tricky. So we have to get a little bit more information about that. So again, I told you that penicillin allergy fades over time. So if it's recent, we're probably going to, again, give alternative antibiotics, but IDs can get involved, and ID to us the initial triage, and then they talk to us on the allergy side to evaluate. And then if it's over 1 year, then we'll have to figure out, well, how long? And so what we've decided to do, is that how long after the reaction did occur? If it's less than an hour, again, that's in the window of a type 1 reaction, right? And again, we'll have to get more information, right? Again, this is with them not seeing anybody. But if it's longer than an hour, then they don't need to talk to anybody. Just go ahead and give them any cephalosporin. And then, again, we could consider challenging the patient, right? And again, ID, thankfully, is doing a lot of this triage for this. And so our protocol would be to challenge those patients, right? And so, again, we do that in the hospital. We give them a test dose. And again, they're being monitored, and generally it's thought to be very safe to do this. So what about high-risk patients? Well, clearly for severe type 1 reactions, severe reactions, non-type 1 reactions, non-anaphylaxis, we're going to do avoidance, right? But for high-risk type 1 reactions, we're going to consider desensitization, right? And so we're going to induce a state of temporary tolerance where we slowly administer the drug over time until we hit a target dose. And so if we give the drug slowly enough and we fall below the threshold of anaphylaxis, we can hit the threshold dose without a reaction, right? And so once we get it into their system, we can continue that medication continuously, and they can get the drug without a reaction. Now, again, once we stop giving the drug and we get 5 half-lives, then we're going to have to restart, the desensitization for the subsequent reaction. So it's only a temporary induction of tolerance while they're getting the drug. Okay, and a desensitization protocol is given for example. Obviously we would give the full dose and do 2 dilutions, right? So let's say full strength is a gram here. We would do a 1 to 10 and 1 to 100 dilution. And then, we would infuse the first dilute solution over 15 minutes at 2 ml an hour, right? So the patient gets like 20 micrograms, right? So that's not going to induce anaphylaxis. But as we increase the infusion rate, we will hit the target dose of 1 gram over 219 minutes, right? And so when we give it in this slow fashion, slowly increasing, 20 micrograms, 50, 100, 200, and so on, up to the full dose, they are able to get the drug, even if they had anaphylaxis to penicillin. Now, clearly, this is pretty time consuming. It is useful for penicillin is the best drug in certain situations, but we can do this with any type of reaction. The bottom line is, if someone has anaphylaxis to drug, there is no contraindication to receiving it. So, this seems to be a pretty broad initiative. What would be the benefits? And certainly there's already been some health centers that have estimated the cost savings to the institution by implementing these programs. So one systematic review estimated that inpatient costs for penicillin allergy, like I mentioned before, is $11,000 to $4,000, right? And that's just cost. But what about actually implementing the program? Well, if you do an economic evaluation study, which is more theoretical, the potential cost savings in the U.S. could be between $1,400 per inpatient or $256 per outpatient, right? An actual study that measured costs found that if you just did it just in the ED, just in the pediatric ED, a delabeling program, assuming delabeling 6,700 patients a year, would be $190,000. But I mean, again, like I said before, let's say you have 10, 20,000 hospital discharges, and 10% of those have allergies, so that's like 1,000 people. If you do 1,000 times this, you're hitting like $1.4 million. You could easily, I have to say this, right? You could easily pay for the salary of an allergist immunologist to implement this, right? So if you think about it, there is potential for reduction of healthcare waste by implementing these penicillin delabeling programs with appropriate risk triaging. Now, again, it's easier said than done, but a multidisciplinary effort between infectious disease and allergy immunology can achieve these outcomes with significant cost savings to the institution. And so, again, going back to our questions, for a patient with a remote history when she was a child, and again, I guess my criticism, I didn't put how long the reaction was long ago. So let's say it was over 10 years ago, I apologize. We probably would offer the patient a challenge, right? Again, some places are equipped to do this, some are not, right? And then, again, I wanted to get to the point here that, interestingly, because of the loss of cross-reactivity between cefazolin and penicillin, you could actually directly proceed to giving cefazolin with probably minimal risk. And actually, there was a recent study that just came out that I had not a chance to put into this article that shows that the concurrence of penicillin allergy and cefazolin allergy is immensely low. So again, I'm not sure if this is dogma yet, but there's, again, more and more evidence to show the safety of cefazolin, even in the context of known penicillin allergy. So again, in summary, I hope I convince you the individual systemic healthcare burden due to inappropriate drug allergy labels. And so certainly if we are empowered to evaluate the risk of these and potentially delabel them through testing first or direct challenge, if appropriate, we can eliminate incredible amounts of wasteful spending in the healthcare system, and most importantly, improve healthcare outcomes. Again, I appreciate your time, and I guess we have a few minutes to take questions.
Thank you, Dr. Lee, for an outstanding presentation. This is great this morning. And if anyone has a question, you can unmute your microphone and ask, or if you would like, you can type your question in the chat area and we can read it for Dr. Lee. Would anyone like to
Jared, can you hear me?
Oh,
yes.
Go ahead.
Yeah, sorry, I don't know, my video turned off or something. I think I hit a button wrong on Blue Jeans here. Fantastic talk, Jerry, and I really appreciate the whole bench to actually health system science to population outcomes discussion. So actually, I have a question more on the distal end, actually, which is, how are you and your colleagues at Emory, attempting to, quantify the potential cost savings, because there are potentially different ways of doing it. And when you go to the department chair for funding for these types of programs, they're often asking, what kind of evidence. And so I'm just curious, how that's potentially being tracked and hopefully to be able to justify and potentially grow and expand the program at Emory and other institutions you're working with.
I mean, I think we're looking at the same outcomes I mentioned before. We're looking at rates of resistance. We're looking at length of stay. We're looking at use of alternative antibiotics. We're using to look at non-ideal antibiotics. So again, there's process measures we're looking at, but also, again, some of the known complications of penicillin allergy, inappropriate penicillin allergy labels, we're quantifying those and seeing pre and post intervention, how those have reduced. Now, actually translating the cost obviously is a little bit more challenging, as you can imagine. It's very complicated, and certainly there is a lot of pushback administrations like that, but certainly we do have more and more studies out there that show general, again, estimates on improvement in reduction in waste. And so if you, again, show the data that you're hitting the same metrics, achieving those cost savings, it is somewhat of a surrogate. But again, we have yet to have that conversation yet, so I'll have to tell you how it goes.
Great. I also have a follow-up question. It gets to the maybe one of the proximal issues, which is the labeling component, right? Which is different EMRs, whether you're on Cerner or Epic or whatnot, have different ways of documenting or documenting suspicion of a penicillin allergy. And I'm just curious what you have seen or what discussions in terms of the labeling and the justification for the labeling, and whether there are best practices that you've seen emerge in EMR documentation, tied to what you were discussing earlier that should be implemented.
Oh, there's a recent article that actually has gone over some of the implementation of these clinical decision rules, and they actually show pictures from different EHRs. I actually don't have the reference on me, Tal, I apologize. But essentially, it is, I hate to say this, the best way to change behavior is to, again, place a algorithm in your electronic health record where the user is forced to do data entry, right? And again, if we sort of educate people on what to do, they're going to walk your lecture and they're going to kind of forget it in a day or so. So real systematic change does require specific clinical decision toolkits and so on baked into the software to so they can't get out of just putting unknown or just doing something perfunctory. So, essentially, I can share that reference if anyone's interested in. But again, this has been successfully implemented. These sort of forcing the person putting the data entry to put in specific information. And again, that is ultimately one of the components you're going to need, accurate labeling as well. And I'm glad you brought that up.
Great, thank you. Jason, do we have any other questions?
Let me see. Would anybody, again, if you would like to ask a question here of Dr. Gerald Lee, you can unmute your microphone, or if you'd like to type it in the chat area, you can do that as well. If we still have a couple of minutes here. Well, Dr. Lee, I think you explained it so well.
Yeah, exactly. I do see a couple of our allergy colleagues out there. Derek, are you still there? Derek Damon? Curious whether you have any thoughts or comments and your experience in the outpatient arena when you were working with colleagues. I don't know, Derek, you're still there.
I am actually here. No, I talked with Jerry yesterday, and we had. Can you hear me?
Yeah. Hey,
nice
good to see you, man.
Awesome.
Hello, everyone.
Cool.
Hey.
Yeah, so talking with Jerry yesterday, it was just kind of nice to confirm, what seems like a little more of a cavalier approach, but really all the data shows that, I've moved to just keeping a big bottle of amoxicillin here in the office, and if someone has a vague history, I'll be happy to give them a dose and challenge them right there on the spot and watch them for an hour before they leave.
And what's your outcomes?
Oh, just cute. I feel like so far we've had a 100% success rate, and if anyone does, they may call back and say they may have had a mild rash, a couple of days later. But I'm like, well, we are definitely refuting more of these labels, and I'm sure this will eventually, help not only decrease costs, but also hopefully reduce VRE and C. diff and all of those complications.
Excellent. Thank you for sharing that. That's awesome.
Excellent.
Thank you.
Thanks, Derek. Jason, do we have any other questions? I'm not sure. Is it just coming through chat or any other place?
Doesn't look like it at this point. So, Dr. Gerald Lee, Dr. Tao, thank you for getting this. Thank you for arranging this. I know it was a year in the making. But we really appreciate it. And Dr. Gerald Lee, thank you for an outstanding presentation. And I don't know if you remember, but we had a tradition. We still have a tradition here with the Department of Medicine Grand Rounds in the past, every time you've spoken, you were a UofL faculty member. But now that you're not a UofL faculty member, and this is your first visit with us as a guest presenter, you are going to get one of the coveted Louisville Slugger bats. So you're going to, so we're going to get you one of these things. Awesome. We will get it UPS will drop it off for you probably early next week. But I just want to say thank you it was great seeing you again. I know a lot of folks, a lot of folks are familiar with you still, and I'm sure everybody was really happy to see you again. And not only that, but an outstanding presentation. So thank you again.
Oh, thank you again. I appreciate the invitation, and I can't wait to see everyone again when I go back to Louisville. Everyone has a wonderful day, and thank you so much for listening.
Thank you, and thank Dr. Towley. Thank you again. This is as I said, outstanding.
Yeah, no, great. Well, first of all, Jerry, thank you for being so patient for us to, rearrange and then, because of the original pandemic situation, but to be able to come back and give this talk. So really delighted to see you again, and hopefully we'll have you here in person and sometime in the future. Be able, partake of the Louisville food scene again and the fantastic coffee here.
Oh, I'm looking forward to it. Thanks again, Tao.
All right. Thank you.
All right.
Well, thank you, everyone.
Everybody.
All right.
Thank you.
Bye-bye. Have a great morning.
And I want to thank everybody for joining us this morning. We'll be back next week, same time, same channel, 8 a.m. next Thursday. Our speaker will be Dr. Kimberly Pate from the Internal Medicine Division, and as many know, she is the director of the Palliative Medicine Fellowship. So it should be an outstanding presentation as well. So I want to thank everyone for joining us, and again, we'll see you next week, next Thursday, 8 a.m. And Tim, if you're still here, I downloaded the thing.
All righty. Also, when you go in to look at the recordings,